Hi, my name is Dr. Ronak Patel, and I'm a board-certified orthopedic surgeon specializing in sports medicine and complex knee injuries. Today, I'd like to talk to you about ACL reconstructions. So there's no shortage of ACL reconstruction information or video out there, and certainly for good reason. There's a lot of different ways to do an ACL reconstruction surgery, and there's a lot of different graft options when it comes to ACL reconstruction surgery. And now there's ACL repair surgery as well. But today I'd like to focus on anatomic ACL reconstruction surgery. So what does that mean? Well, the ACL, we know, is the main rotary stabilizer of the knee. It is a ligament that connects the femur to the tibia. But it comes in at an angle, so it's not a straight up and down ligament. What it does is it comes in from the outside of the femur and attaches to the front of the tibia. And because of the angle that it comes in at, as well as the location points on where on those two bones it inserts, it provides a rotary stabilization to the knee joint. So when you land from a cut or a pivot or a jump, it provides stability in multiple directions. That stability is not recreated based on a up and down ligament or a ligament that is not put back exactly where it belongs. And that's what an anatomic ACL reconstruction does. It puts the ACL back where it belongs, or where you were born with it. And in an anatomic ACL reconstruction, the surgeon, in my case, we would measure down to the millimeter exactly where the tunnels should be where the graft is placed. And if we're not measuring down to the millimeter, then we're not accurately or anatomically reconstructing the ACL. Anatomic ACL reconstruction allows for a quicker recovery, but not just a quicker recovery, a better recovery. It allows for stabilization of the knee so that it feels exactly how it did before it got injured. Historically, when patients had what we called a non-anatomic or transtibial ACL reconstruction, patients would get back to feeling 75 to 80% of their normal function, but they never got back to 100%. And those days are not currently what we recommend for ACL reconstruction surgery. We want complete restoration of function with no residual laxity. And so in order to get that, you need to have an anatomic tunnel placed on the femur and an anatomic tunnel placed on the tibia. And that is done by the surgeon. And so it's the surgeon's responsibility to put the tunnels exactly where they need to be so that the patient can recover the way they should recover. In fact, there's so much emphasis on anatomic ACL reconstruction surgery that recent technologies have been developed, including spatial surgery assistance in the OR that'll help a surgeon put the tunnels and the ACL reconstruction tunnels exactly where they belong. That allows for again, a anatomic ACL, an ACL that is placed where it belongs, and that allows for the patient and the physical therapist to move it along appropriately after surgery. So this technology, which is new in the recent weeks in the sports medicine world, is exciting for surgeons to be able to utilize to help confirm anatomic placement of the ACL reconstruction. But does it replace a clinical judgment or a surgical judgment of the surgeon? Absolutely not. It is still our responsibility as the surgeon to make sure we're doing the right thing for the patient and double checking and triple checking exactly where we drill those tunnels so that the patient gets the best outcome possible. If you're interested in hearing more about anatomic ACL reconstruction surgery, please feel free to watch some of our other videos or come in and see us, and we'd happy